contraception is one of the most widely used medical interventions in the world. Millions of women rely on these medications every day. Acquiring these prescriptions has become increasingly frictionless. Telehealth platforms and digital clinics now offer instant access based on a quick online questionnaire, often bypassing the traditional in-person medical evaluation. Treating hormonal birth control as a one-size-fits-all commodity carries a severe blind spot. Every patient has a distinct medical profile, and introducing synthetic hormones without a physical assessment ignores specific, hidden physiological risks. This chart shows the relationship between upfront clinical evaluation and the risk of adverse events. An immediate, low-effort prescription leaves you in a high-risk zone. Securing a safe outcome requires upfront effort to properly screen your medical history. Bypassing that diagnostic friction for the sake of immediate convenience exposes the user to unpredictable biological reactions. Estrogen-based methods are biologically potent. These hormones suppress ovulation while simultaneously recalibrating your cardiovascular and metabolic baselines, altering how your body regulates blood pressure and clotting factors. Introducing synthetic estrogen into the wrong patient profile can trigger life-threatening complications. In vulnerable individuals, these hormones act as a catalyst for severe cardiovascular events. The primary threats include myocardial infarction, stroke, and venous thromboembolism, or VTE. VTE is a condition where a blood clot forms in a deep vein, most commonly in the leg, and can travel to the lungs. These outcomes are statistical realities for specific subpopulations. Factors like family history, current medications, or underlying health conditions compound the risks associated with estrogen. The purpose of a pre-pill evaluation is to accurately map your biological profile to the correct hormonal or non-hormonal option, preventing these severe reactions. The first required evaluation is the cardiovascular and clotting audit. Your provider must check your blood pressure because estrogen activates ROS. The renin-angiotensin-aldosterone system, or ROS, is a hormone system that regulates your blood pressure and fluid balance. Estrogen stimulates the system, pushing your blood pressure higher. Prescribing combined oral contraceptives to a patient who already has uncontrolled hypertension multiplies their risk of experiencing a stroke. The next critical cardiovascular metric is your body mass index, or BMI, and overall weight assessment. Clinical obesity carries an inherent increase in clot risk. Furthermore, excess weight alters the drug's pharmacokinetics. Pharmacokinetics refers to how a medication moves through and is processed by the body, meaning the birth control might be less effective in preventing pregnancy for obese individuals. Combining a patient age of over 35 with an active smoking habit drastically accelerates the body's production of clotting factors. This pathway shows how each cardiovascular variable acts as a vital input, directing your provider toward a safe prescription. Reporting high-risk cardiovascular markers diverts the patient away from combined pills and toward long-acting reversible contraceptives, or LARCs. LARCs include devices like IUDs and arm implants that provide years of highly effective estrogen-free pregnancy prevention. Disclosing cardiovascular strain disqualifies you from standard pills, but it is the critical barrier needed to prevent a fatal cardiovascular event. The second major evaluation is the neurological audit, which focuses strictly on your history of headaches. Providers distinguish between standard migraines, which generally allow for the cautious use of hormones, and a strict red flag, migraine with aura. An aura is a specific neurological symptom that precedes the headache. It often presents as visual disturbances, flashing lights, blind spots, or sensory tingling in the face and hands. Introducing synthetic estrogen to a patient who experiences auras severely amplifies their risk of an ischemic stroke. An ischemic stroke occurs when a blood clot blocks or narrows an artery leading to the brain, cutting off vital blood flow. This updated pathway shows how neurological inputs change the clinical routing for a prescription. Presenting with an aura turns the pathway red. It serves as an absolute contraindication, meaning estrogen must be completely avoided. Accurately reporting these visual disturbances forces a pivot to non-estrogen methods, neutralizing a documented stroke risk. The final hidden variable involves the metabolic and pharmacological audit. Your liver is the primary site of hormone metabolism. It is responsible for breaking down synthetic hormones and clearing them from your system. Active liver disease or hepatic tumors severely impair this process, causing drugs to build up to toxic levels in the bloodstream. Your provider must also check your current prescriptions for enzyme inducers, like rifampicin, phenytoin, or carbamazepine. An enzyme inducer is a substance that forces the liver to speed up its ability to process other chemicals. These interacting drugs force the liver to metabolize your contraceptive hormones too quickly. By clearing the estrogen and progestin out of your blood faster than intended, your protection drops, reducing the effectiveness of the birth control. This final logic branch shows how the liver and other medications interact with hormonal inputs. The presence of enzyme inducers leads to a high risk of contraceptive failure, pointing you toward a dual contraception strategy. Identifying a medication conflict requires the extra effort of adopting backup methods, but it eliminates the risk of an unintended pregnancy caused by drug failure. This matrix shows the red flag checklist used by the World Health Organization to map patient safety. The 5 absolute contraindications include uncontrolled blood pressure, a history of VTE, migraine with aura, severe liver disease, and hormone-sensitive cancers. This mapping rule is strict. Triggering any of these red flags immediately diverts the patient away from combined oral contraceptives and toward non-estrogen or non-hormonal alternatives. For a young, healthy user with normal blood pressure and no smoking habit, combined oral contraceptives remain an efficient and safe option. For a user over 35 who smokes or experiences auras, the medical effort of a LARC insertion is a necessary investment to protect their physiological baseline. Safety is entirely dependent on matching the drug to your specific physiological matrix. Never accept a hormonal prescription without a provider taking your blood pressure and asking about your history of headaches. If a telehealth app or a clinic relies entirely on a brief questionnaire, you must proactively volunteer this information. Secure a 3-month follow-up appointment to monitor your body's tolerance and track any changes in your blood pressure. You can use this clinical framework to organize your medical history and self-advocate at your next appointment. Ultimately, a comprehensive medical audit ensures your final choice of birth control is supported by your actual biology.